Lovely. So, good evening, everyone, and thank you so much for joining us today. It's lovely to see so many of you here already, and I know there'll be a few more logging on over the next couple of minutes now. So, today we're here to talk about why people say no to a transplant. So, before we begin, I just have a quick reminders to help you run the session smoothly. If the slides want to run smoothly, there we go. So firstly, this webinar is being recorded so that we can share it with others in the kidney community who may not be able to join us live this evening. So if you do have any questions during the sessions, please feel free to pop it either into the chat box function, or if you raise your hand, I'll be able to unmute you so that you can ask the question directly yourself. As we're running in a webinar mode, all attendees are automatically muted to help minimize background noise. Please don't feel that that stops you from asking questions. If you just raise your hand, it allows me to unmute you and then you can go ahead and ask any questions you may have. So before we start, I'd just like to briefly highlight the aims of this evening's webinar. So firstly, we want to recognise and respect that choosing not to have a kidney transplant is a valid and very personal decision. We also hope this session helps loved ones better understand that decision and how personal experience can shape the way someone feels about transplantation. And finally, we want to support informed decision making by exploring some of the risk benefits and the importance of future planning. So, this session really is a chance to listen, learn, and understand the many different reasons why someone might decide not to go ahead with a transplant. There is no judgment here, just an opportunity to hear real experiences and open up an important conversation. So, with that said, I'm really pleased to introduce our speakers this evening, which is Mr. Mike Stevens, the consult transplant surgeon at Cardiff Transplant Unit. And Mike will be leading a conversation with Emma today, a clinical nurse specialist and researcher. So Emma will be sharing insights from her research into why some people choose to say no to a kidney transplant. So Mike, I'll hand over to you.
Brilliant. Thanks a lot, Georgia, and welcome everybody. Real pleasure to be involved in this session this evening. Emma and I have known each other for a long time, and this particular topic, obviously very close to my heart as a transplant surgeon, but also one of the things that we've been talking about across Wales, actually across the whole of the UK, probably the whole world, but certainly we've been discussing this particular topic in Wales for quite some time. So it's great that we've got an opportunity now to get to hear directly from Emma about what her research has shown, and feel free to interrogate her. She's asked for as difficult questions as possible. That's what she would prefer. Nothing straightforward. Yeah. So Emma, I think what we'd agreed we would do is I'll ask you a few sort of brief questions, and then we'll just see where the discussion goes. So everybody, just please feel free to add any questions as you want to. Pop your hand up and we can get you involved if you feel up to it. So, Emma, before we ask the first one, any comments from you?
No, I'm good. Thanks, Mike.
Okay. So the obvious first question is, why did you choose to do this research? And I suppose the kind of background to that is that this is not research is something we do a lot of in healthcare, isn't it? But it's not something that everybody does, and particularly working in busy clinical fields like you and I do, isn't necessarily the normal thing to sort of take time out to do this sort of thing. So I'm really interested in why it was that you wanted to do this particular thing, because maybe you can explain to her, but you did take out a fair bit of time out to do this, didn't you?
Yeah. So thanks, Mike. That's a really, really good question. So I'm a nurse by background and have worked as a kidney nurse for over 21 years prior to starting the research. And as a nurse, research isn't something that we necessarily think about doing, independently. And really, the reason why I'd chosen to do this particular research was the research question. I'd been a transplant specialist nurse for around 11 years prior to leaving my whole time nursing role, and some of the things that as nurses we help support people through their kidney journeys, and that involves a lot of supporting people and their families whilst they're making various decisions. So my role as a transplant nurse specialist was to give people information about transplantation, the benefits and the risks, and really help support them then and the families while they were making decisions. And one thing that was really unclear for a long time in my nursing career was why some people make certain decisions and others don't. And this particular question had come from my clinical practice. So we noticed in the area where I worked that there were a number of people who had decided against having a transplant, but it was quite unclear really their reasons. Some people had had transplants before and decided against having another transplant. And some people had decided right from the very beginning that they didn't want to have a transplant, versus other people who were on the transplant waiting list and then had declined a call when they'd been called from the transplant centres. So it was really very clear when the research question had been developed into a research proposal that it was a really, really interesting one, and such an important and probably a very different opportunity for me to do as a nurse, since as I'd been with people throughout their kidney journeys. But this way was a different way to explore reasons, and coming out of clinical practice to be able to take up the research was really important, because it's not something that we often do as nurses, but we're often involved throughout throughout the conversations, but then really trying to explore in a very different way as a researcher was really, really a massive experience for me, and something that I really massively appreciate, really. Thank you,
Yeah,
Mark.
it's really interesting how this sort of came about, and probably again worth people knowing that Kidney Wales Charity contributed to the funding of the research, didn't they? And that was one of the things that, as a charity, Kidney Wales does fund a lot of research across the country, but this was a particular effort from the charity to try and support our non-medical colleagues, so our nursing and our allied healthcare professionals into research projects, and this, your project, as your research project, has shown very clearly that was an excellent decision, because this is really fantastic outcome. So fine. Shall we, Emma, anything else to add on the
Yeah, no,
why?
no, no, and I think that was really important for me. It's coming from a very different perspective. It was put out for many people to take up on the opportunity, but I think for me, just having that, the ability to see this from a nursing perspective, but also really taking a step back out of clinical practice to be able to really understand people and their decisions. So I wasn't kind of being pulled from clinical area back into being researcher. It was, as I say, such a privilege really for me to be able to take myself out of clinical practice and be able to do this research and be there to hear people's stories, and really privilege, give them real privilege really as I was trying to do that and do the piece of research.
Grill? Well, you did a great job, Anna, that's for sure. Okay, so yeah, I think you've covered those things really in that slide. I mean, should we go on to the next question?
We have, but just before we do, we have had one question in the chat
Okay.
Yeah, of
box,
Oh yeah, I
course.
see that.
and
Where?
it was just asking what is classed as a good kidney match from a donor.
Okay, yeah,
Would
that's a
you
great
touch on that
question. It's one of
quickly?
the ones that people ask, or goes through the mind a lot, I suppose. Now, it's not an easy one to answer, because it's not a simple answer. There are lots of different facets to what makes a good donor. In general, we're looking for somebody who closely matches the recipients, essentially. Now, that is in terms of their age, ideally. The younger the donors, the better in general, but also in their tissue type. So the tissue type it's a little bit like blood type, but slightly different, and it's about how each person's immune system recognizing other people's immune systems, right, other people's tissues. So the way that we measure this is with three different we call them matching on three different scores, and you can score 0, 1, or 2 on each one. So you can ultimately end with 6 matches or 6 mismatches or any combination of that. The best match is 0, 0, 0. That means that your tissue type matches closely with the between the donor and the recipient, and the worst is 2, 2, 2. Um, Now, 2, 2, 2 can still be a very good transplant, particularly if it's from a live donor. Live donors in general produce really excellent transplant outcomes, so a 2, 2, 2, you may not be too disheartened with that. But ideally, we aim for something better than that if we can. So it's not as simple as saying there's a good or there's a cut-off. Lots of different factors involved in that. Okay, should we
Amazing.
go to the next bit?
And then there's one more question here for Emma. It says, congratulations on completing the research. What were your key findings around those who declined a kidney when called? And were they largely for physiosocial reasons?
Okay, thanks, Georgia. I'm hoping really as the presentation progresses, the key findings will be shared towards later slides. And yeah, absolutely, I'll hopefully be able to return to that question and make sure that I've answered that. And thank you for congratulating on the research findings. And I said, hopefully some of you may even have read the paper as well. So with dissemination through catch-ups like this with Mike, and really from what has already been published, it's really important that we get the findings, circulated as wide as possible as well, really for there to be understanding from not necessarily just clinicians, so doctors and nurses, but then other people really in their families. So it's really important that we've got situations like this tonight that we're able to share these findings. But I will return to that later on, Georgia, if that's okay.
Amazing. No, that's great. Thank you. And then just one more question before I hand back over to Mike. Someone has asked, is there an age limit for a donor?
No, not really, no. The real extremes of upper age tend to start making it less and less likely that the kidney will be suitable, but certainly we've had live donors aged over 80 years of age, and we will, in some circumstances, consider deceased donors aged over 80 as well. So I guess it depends a little bit where you're coming from on that. If you are considering donating to someone in life, then go and speak to your local transplant unit, and they'll go through the specifics with you as an individual, because it's not the age, it's how healthy you are really. And if you would like to be a organ donor after you die, then age is absolutely no limit. And remember that if you do want to donate after you die, it's not just organs that you can donate, it's corneas and tissue and things like that. And the upper age limit there is much more relaxed. So there's a good chance you can still donate at any age if you really want to. So make your decision, share your decision with your family, so that they're aware of what it might be, and then there is an opportunity for that to happen after you die.
And then Mike, I'll hand over to you for the second question.
Okay. So the question's there on the screen for everyone to see, and it's obvious really. What was the main question you were looking to answer here, Emma?
Okay. So really the two main questions that I was looking to answer. So I first of all started with looking at evidence from other people's research. So it was really key to find a starting point. I knew what we'd found in our clinical area from an audit, which was just looking at the more the numbers of people that were being transplanted, and we found then that there were a number of people that potentially could have been transplanted that weren't. So it was then trying to unpick that a little bit more at more local level, so within the health board. But then when I started the research, it was to look at really what was already known, and that's really a key point to start with any research is starting to find out, okay, well, these are the kind of things that we want to know, but what is what is known already. But the key things that I wanted to find out were what influences people's transplant decision making, and really what influences that, and not necessarily from the point of view of not wanting a transplant, but then what influences their decision making right from the very start. Is it something that people decide from the beginning? Is it something that people then decide they may want a transplant, but then later on decided against having one? And what does that look like? What does that look like on the people's journey? So my first point was to go to the research and find out how people were making decisions, and looking at the data that found from like international studies. And that really got broken down into looking at that there were times when people were finding out their information. Then there were elements then where people had the information, but then how ready were they to decide about their kidney options, not just transplant, but just looking at their options, whether that was the information they received, hadn't received, was the information they received too much, too little. And then I looked at okay, well, what were the reasons why people decided about having a transplant, and then decided about not having a transplant, and then looked at the decisions as well, and their experiences whilst those that had decided for having a transplant when they're on the waiting list, what really influenced their decisions then, because that was the other key thing that we'd found locally, that people were having a transplant. Sorry, Georgia. But when people were on the waiting list, that sometimes then they decided to come off the list, or people when they had been called by the transplant centres, that then they decided against having the transplant. So really that was the first thing I looked at, was looking right across almost like the person's journey from finding out they had kidney disease, what information they had, right through almost to being on the waiting list. But then specifically then my research then wanted to know, why do some people then choose to have a transplant while other people don't want to transplant? So in other words, why do they not want to transplant? Why do they say no to having a kidney transplant while they're otherwise suitable? So I think that probably takes me to the next slide. Please, Georgia. So hopefully this doesn't look too busy for you, but it was really important to map out for us then as doctors and nurses and other healthcare people, to look at really where do people make decisions, and where along this kind of journey can people's decisions change. So I looked at this really right from people having a kidney failure, and then really the top line kind of like shows that, okay, well, if people know that they've got kidney disease early enough, so within the first year really of knowing that they're going to be starting kidney replacement treatment, that they should be receiving the information about kidney transplant to be able to start their decisions. Some people may then be on dialysis first and then opt for a transplant. Other people may be able to know that if they know they want to have a kidney transplant before they start dialysis, they may potentially have a living donor, or they may potentially be placed on the waiting list before they need to start dialysis, and potentially then receive a kidney transplant, what we call preemptive kidney transplant. Some people otherwise may be seen at the transplanting unit and then go on to the deceased, the waiting list for a deceased donor. And again, then they would go onto the waiting list and then potentially have the transplant. Other people may start their dialysis in a very unplanned way, and they start dialysis as an emergency. And they have no time really to have these any kind of form of conversation with their kidney teams about dialysis, about transplant, about anything. And then really they would only start and begin to discuss their options when they've started on dialysis. What I found when we were looking at this kind of pathway, people's decisions can be affected in various points of this. So some people may start, they're diagnosed, and because they've had an emergency start, they're unable to make any decisions and may wish to revisit these decisions at a later point. Some people start dialysis and then remain on dialysis and choose not to have the transplant. Other people may change their mind and disengage from any part of this process. So they may opt for a transplant and want to go and see the transplant consultants and then decide against going to see the consultants. Other people may be even placed on the waiting list and remove themselves. Other people may remove themselves when they've had a call from the transplant centre. And other people may have been transplanted before, but then decide against having another transplant. So it was really key to look at all of this, not just, it wasn't a simple, why do some people have a transplant and others not? It was really to try and understand what that looked like, really, where people can make decisions and where people may decide about their various decisions along the way.
Oh, that's a great description, Emma. Thanks. And obviously really detailed, well, nice detailed diagram that you've got here, but it highlights the complexity, doesn't it, of these decision-making processes, and that it's not as straightforward. A lot of people might think, oh, this is a really simple decision. I want a transplant, or I don't want a transplant, but actually there's so many other facets to it, as your work has highlighted. Okay. There was a question about, yeah, which we're going to cover off, aren't we, as we go through into the next bit. Emma, was there anything else on that last question, or shall we go into the details of what you actually
Yeah,
did?
yeah, that'd be great.
Because I think that'll pick up Sam's question as well, won't it, then, about who was involved. So what did you do? How did you do this? Where did you do it? Who was involved? As much detail as you're able to give us, please. That'd be great.
Grant. With the next slide then, please, Georgia, that would be great. So initially I had set up to do, because the initial funding for the project had come from Wales, so from Kidney Wales charity, and it was funded through a CES scholarship with Bangor University, and also part funded by other charities that sat in Betsy Cadwallader, which is the North Wales Health Board. So initially it was to understand what people's perspective and views and decision making was across Wales. So was this just something that was happening in the area where I worked, or was this something that other people decided in other parts of Wales? So I started the research in 2021, and we're still, I hate to say this, but it's still COVID. So I had to have lots of kind of like backups really with the research. And initially it was just to set out and find out the people's views and experiences of decision making for those that lived in Wales. So recruiting from the health boards up in North Wales and down in South Wales, which generally would cover all of Wales. Now, despite people being, so each of the health boards then looked through their lists of people that had made decisions that had decided, people that had decided against having a transplant. There were more people that were invited to take part than who took part. So that's really, really important to understand. Although only 30 people took place throughout the study, there were lots more people that were invited, so who had decided against having a transplant, who then decided for whatever reason not to take part in the research study. Because the numbers, although they were lower of what I would have liked from people's perspectives in Wales, it did give me the opportunity then to recruit from outside of Wales. So you can see, I think there's a little blip on the on the map. So the little green bits probably need to be a little bit more, that kind of area. But this hopefully gives you some indication that people's views I was able to capture from across Wales, but then also into like the borders of where we are in Wales, so around into Shropshire and Cheshire, to the northwest. And then I also had reached out to more the another big health board in England, which also had people with different kind of various background as well, but to give a perspective of people a little bit more broadly. So 6 NHS sites were recruited from, so 3 in England and 3 in Wales. Circulated the advert as well through kidney charities. And then people then approached me about taking part in the research. And then when they spoke to me, then I gave them more information about taking part. People were offered and took the offer of a £25 gift voucher as well to take part and to be interviewed, which was a really small token, hopefully, of us, some gratitude really and appreciation of their time, because people did give me a lot of time. I interview people on the phone, via Zoom, Teams, so virtually. And then I also met some face to face in their homes, dialysis units, a cafe. So everybody had the opportunity to meet with me, whatever suited them, around their dialysis schedules. And really, it was really important for me to be able to offer whatever was flexible to meet their needs, to meet up for an interview. So 30 people were interviewed, living with kidney disease. So they were, 10 people were on a home dialysis treatment. And 3 of those were on the overnight peritoneal dialysis and 1 on the daytime peritoneal dialysis. 6 were on a home dialysis or hemodialysis, so either daytime dialysis, home hemodialysis, or overnight home hemodialysis. And then 15 were on hemodialysis, either in a dialysis unit or satellite unit, and 5 people had not started dialysis. So I was able, then, that was really important as well, to try and to hopefully explain, to capture decisions as well with people's ages. So, from people that were younger. So the youngest person I interviewed was 34, right through to somebody who was 80, sorry. The 19 males aged 34 to 80 and 11 females aged 37 to 83. So again, that was really important to be able to interview people from different age ranges, males and females, and again what types of dialysis they were on. So as I say, the majority were on dialysis, so, and 5 people weren't on dialysis, but it's really important to get the perspective as well of people that hadn't started dialysis. So again, it's almost like building this picture of, okay, well, what's the perspective of people that are not on dialysis, what the perspective of people that are on dialysis but different types of dialysis, and what the perspective as well of those people who had previously been transplanted. So I had 3 people that had been previously transplanted, 2 that had been transplanted twice and had decided against having another transplant, and 1 had been transplanted once and had decided against having another transplant. So it's really important to kind of capture this, as many perspectives as I could. And then everybody was sent like an interview schedule, so a list of kind of questions that could be covered and want to be covered throughout that interview, and they were sent that ahead of the interviews, and then afterwards, with all the data, it was then analysed with a qualitative data analysis approach. I hope that
That's
captures that, Mike.
Yeah, that's great, Emma. And really clearly a really broad range of the patients, isn't it, from all the different ages and backgrounds in terms of what their renal replacement therapies are or where they are on their kidney pathway. Um, can I just check, were the 30 people who'd been deemed potentially suitable for transplant? So they would normally have been put through the system and assessed, but then they had chosen not to be assessed any further, hence them coming to your attention. Is that correct? Yeah.
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 Yeah, so the inclusion criteria, when sort of when the health boards were approached, they had a list of people who I wanted, the kind of people that I wanted to speak to, and that was those people that were suitable, and I decided against having a transplant
Okay.
for whatever reason. Yeah.
And Richard's asked a question there about what age band were people who accept or decline a transplant. So you've got obviously a broad range here. Was there a sort of cohort within that? Were there more of a certain age, or was it just spread throughout?
I think the next slide will pick up on that, Mike. So, and I'll
Okay, can we
carry
go
on
on
then
to that?
answering that question, Richard. That would be lovely. On the next slide, then, Georgia. The main findings. So this
Yeah,
goes into this one really,
there we
here
are.
really, Mike. So it gives a little bit more of a breakdown of people's ages there, if you can see on the slide. So you're right, Richard. Yeah, I even though I included people of various ages, it was interesting that there were majority of people, well, I wouldn't say the majority, there were more people, 2/3 of people that were in their 60s, 60s and 70s. So I was quite interested, even though I was able to interview a wide demographic of people and their ages, 2/3 were actually in their 60s and 70s. So that it probably brings me then nicely to this slide, which kind of gives a little bit of a breakdown of where people or made a decision based on what I showed earlier on that bigger kind of flow chart. So I kind of broke things down again. And again, it doesn't show people's decisions at the minute or the reasons, but it does give us a little bit more of an understanding as well of where people made their decisions. And I split that down into where kidney transplant decisions have been made locally with their team, and then into where decisions were made with their kidney transplant centres. So it was really interesting. Out of the 30 people, 14 people had decided against being assessed right from the very beginning. And that is probably quite a high proportion of people. So decided straight away that they did not want to be assessed for transplant eligibility. So didn't want to be assessed or referred or had any of the transplant tests or the investigations that would be needed to see if they're suitable. So their kidney transplant or the kidney teams locally decided that they were suitable, but then these people decided actually no, that transplant wasn't what they wanted, and it wasn't for them. And that was really, really kind of important because all of these people had received kidney transplant information. So everybody that I interviewed, whether that was that they'd received it after starting dialysis, those people that had to start dialysis as an emergency, there were only 5 people that started as an emergency. And they had then their information after they started, whereas all the other people had information before starting dialysis. And then again, when they're on dialysis. Interesting as well that 2 people had decided to think they wanted a transplant, but then actually decided against having the assessment. Other people had some tests done locally and then decided and refused to go to be seen by the transplant team. 2 people, interestingly, had been referred to the transplant team and then cancelled their appointment. And I remember one lady said, well, actually, I don't really want the appointment. I don't want transplant. Give it to somebody else. Give the appointment to somebody who does want a transplant. So, and hopefully these kind of like stories will come through in the next slides. The people then that made decisions at the transplant centre. So some people they'd been seen by the team and then went on the waiting list. 4 people removed themselves then from the waiting list because they'd decided then against having the transplant while they were waiting, and for different reasons that I'll go on to. 3 people had been called by the transplant centre and then said, no, that they didn't want the transplant, and then they were removed off the transplant list. 2 people were reviewed by their transplant teams, but then didn't want it. Then once they'd been reviewed, they were told they would be suitable, but they didn't. They decided against then going on the list. And 3 people had been transplanted previously that didn't then choose to have another transplant. So again, this gives a little bit more of a background of where people started or where people made decisions. The next slide, I think, please, unless there's any questions at the minute.
No,
Nope, doesn't look like it. Should we go on to the next one?
So the main findings, so they're broken down into kind of like 4 areas, but I think what's really important is that not just one reason was given and shared for not wanting a transplant. So many of the reasons kind of like move between all of these. So people kind of explained all of their reasons, which kind of went into these different kind of themes. So I'll go through each of the themes individually and hopefully begin to answer some. And as I'm talking through the findings, that there'll be little captions of what people shared. Everybody's names, by the way, it's really, really important to say, are anonymised. So all the names so far are not. There were people that had spoken to me, but they're not their real names. And when I was doing the findings as well, it was just an age, so male, female, and kind of like a name that kind of fitted culturally, female, male, and then the age range as well was 30s, 40s, 50s, 60s. So again, just to de-identify, I think that was quite important, because otherwise the next slides will give a name and it's not their real name. So the next slide, please, Georgia. So really, really crucial is that everybody shared some past experience that they'd identified with in a negative way. So whether that be people being found and diagnosed that they had kidney failure in there as a young child or teenager or an adult or somebody that was retiring, everybody shared negative views in some way that had shaped their kidney transplant decisions. So I'll read some of these small, like really little short summarised statements from people. So this lady was in her 70s and she said, I was devastated, but I was quite young. I'd just retired. I was looking forward to my life and I thought it was the end of my life. And that person was speaking about when she was first diagnosed with having kidney disease. Jim, there was always saying that my kidney function was down, but nobody was ever doing anything about it. Kidneys were in such a bad state that they would never recover. Hannah, she'd never forgiven her healthcare team because she thought that she'd had her life taken away. She'd had a biopsy that she didn't believe needed to happen. And then she ended up on dialysis and she couldn't forgive her healthcare team for what she believed was something that shouldn't have happened. And she really did develop a mistrust towards her healthcare team. Helen, a wall had come down. So for her, everything then from her experiences, she couldn't move past what had happened before with her. Fred had been on intensive care with sepsis, and he felt really that everything that he'd gone through, he was just really glad to be alive, and his wife was happy for him to be alive. So transplant for him was ruled out quite very, very early on because he just wanted to be there with his wife. She'd been through so much with him. Summer had previously had a transplant, and for her transplant, she believed she was such a young woman, and she thought that transplant would be a fairy tale ending. And she found out the hard way. Her kidney transplant failed, and she found then that actually she found out the hard way. Her dreams didn't really kind of have this happy ever ending for her. And then another thing that people told me about some of their experiences of medication that's used for kidney transplants. They'd been on previously for other health conditions, so for other kidney related conditions. And this lady said, actually, I'd vomited, I had diarrhea, I was so poorly when I was on those medications that she then decided that she couldn't possibly want to take those medications again. And that had led her then to think, well, she didn't want to be feeling the way she was before, and then went on to decide that she wouldn't want a transplant to have to go through what she'd gone through again. So all these negative experiences, and there were so many. I have a few hundred pages of what what with the whole project, and well over 130 pages of the various reasons, and of lots of extracts from people's interviews. But people had all experienced negative things that had happened, whether that be through diagnosis, through being under kidney care teams, other teams, so not necessarily just their kidney teams, but all these things had actually transpired and affected the way they thought about transplant and their decisions, kidney decisions. That brings us to the next slide, please, Georgia. So based on that, and again, it's almost like builds and things I say weren't just for one reason, but then building on their negative experiences, people then shared negative attitudes, then beliefs and perceptions towards kidney transplantation. And it's really important to highlight that everybody perceived that there was more of a risk with transplantation compared to being on their current treatment, so for them dialysis. This person said, some people have a kidney transplant and they've lasted 15 20 years. Some people's transplant don't last 3 months and they're back to square one, back to dialysis. Karen said, such and such had her transplant. We were so pleased because she was so young. It's nice to see the youngsters getting them a kidney transplant. Some people then had seen people come back to having had a kidney transplant. Some people that were on dialysis had been on dialysis with other people that had been transplanted who had then died after a transplant. And this really did negatively impact people's experience, people's perceptions of transplant. That if some people may have a transplant and they'll die, and they are the ones that they remembered. They didn't remember those people that then they don't see that have successful transplants and never go back to the dialysis unit because they're living really, good lives, they're healthy, where people that hear the negative experiences of others, it's those things that they remembered. This lady said, a friend of mine, he died after a transplant, and it put her off altogether. Another one wouldn't want to be exposed to get risk of getting cancer. So some people who I'd spoken to had previously had cancer and were worried about the risks of having another cancer after a transplant, and that put them off altogether, really seriously considering a transplant. Martin said, he didn't know how much longer he had left to live, so why waste a kidney on him? So although people had negative attitudes and perceptions towards transplantation, these were based on so many different things. They're based on worries about infection post-transplantation, worried about risks of cancer post-transplantation. I interviewed at the time of COVID, so people were worried about COVID. They were worried then about, okay, well, if it's not COVID, but maybe something else happens in the future. So there were those other things were then beginning to think, well, actually, what are the other risks that they may otherwise not have if they were to remain on dialysis? Some people who had experience to say it was almost not their experience, but the experiences of others led them to believe that transplant wasn't worth a risk. If there's any questions.
That's great, Emma. I guess it's worth pointing out that all of these things will have been explored with the local team, won't they? So these individual questions or concerns that patients had will have been looked through with the individual teams potentially, and so so that they can have some clarification of what the magnitude of the risk is that they're talking about, or how people worried about cancer. What are we really talking about when we talk about risk of cancer? So that they've got able to make an informed decision. That's right, isn't it, Emma?
And then there's another 2 slides, and with the other parts, to the next slide, please, Georgia.
Yeah, just before we go on, we have had one question, and it is there a success rate for kidney transplants? Do possible recipients discuss this in detail?
Yeah, so there are kind of outcomes that we can describe to somebody who's considering whether they want to go forward for a transplant, and those outcomes depend on lots of different factors. It depends on the recipient, but also the donor. So, like we mentioned earlier on, live donor transplants tend to have better outcomes in most aspects. Um, and yes, we will go through those in detail with the individual. Overall, success from transplant is very high. Anyone who's been through the process will know you get a fairly careful assessment of your health before you actually get as far as going on the transplant list or receiving a transplant. So we know quite a lot about people before they're transplanted. We know a lot about the donors as well. So overall, the success rates from transplants are extremely high, and it depends what you call a success, really. If you're talking about short-term success in that the kidney works, the transplant works, you're certainly over 95%. So 95 out of 100 people, that will be a successful outcome. And then if you're looking at it as to transplant still working a year later, you're talking 90 to 95. And then 10 years later, depends a little bit on the donor side of things, but certainly half of transplants we would expect to last for at least 10 years. And if it's from a live donor, half of those would last for 20 years. So, overall outcomes are very, very positive.
The next slide, please. And that did actually affect people's decisions as well, which I think we'll go on to in the next slide. So many people had shared that why they didn't want to transplant and what had affected their decisions. But there was also on the other side that people preferred not to have a transplant for different reasons. Now, the people that I spoke to were, as I said, 2/3 of people were in their 60s and 70s. And those people really did share almost like altruistic beliefs as well. They believed that other people deserved a kidney transplant more than them. So people that were younger or people that, had more of a life to live than them. And that was really, really important that came through in the interviews that people had decided against for them, but actually believed for other people it was still the best option. So Fred, this young guy is there, mustn't be more than 18. He deserves a transplant. He deserves a kidney. People in their 70s and 80s, they don't. Really, do they? And that was really quite hard then to sit and listen to people's stories and what they thought for them, that other people deserved it more than them, was really, it really did resonate with what other people were sharing as well. What was really important as well, and people really felt that their healthcare teams had presumed they wanted a transplant. Some people said, this Marcus said, I was in kidney in the CKD clinic, but nobody'd ever really asked, did I want a transplant? And probably he would have said no from the beginning when they did, if they, had they ever actually asked. And he said, oh, there was an expectation with lots of transplant initiatives. And felt that people, we as healthcare teams were actually pushing these other initiatives, and that this is an expectation that people would want to transplant. Some people spoke about being referred, and okay, so they didn't want to transplant, but then being referred to kidney psychologists, so other people in the healthcare team to try and find out. And one gentleman had said, he wasn't mad for not wanting a transplant, that was his decision, and what didn't we understand as healthcare teams? And again, that's really important, that another message really, that person has made a decision and they've shared that, and we've listened and we've tried to give them the best information that we can, and whether that be the healthcare team and their family, but ultimately, it's their decision. And that was something that was really, really important for me to understand, that people had made, really informed consent and that they'd made a decision. This person, what don't we understand? Doesn't want to transplant, that's his decision. Karen was working out really what was the best option for her. And we needed to understand what the best option was for her. And then another guy, transplant isn't a cure. And it's just another alternative to being on dialysis. The next slide, please, Georgia. So people shared then their dialysis experiences as well, and many of the people who I spoke to had good experiences with their dialysis. They chose dialysis in preference of having a kidney transplant. Marcus said, I'm a dialysis patient, but I look like a really good transplant patient. So he said, he felt that he was doing really well. He was able to do his overnight hemodialysis at home, and he had, really, really good blood results. He had really good quality of life, very little medication. So for him, that was the best treatment choice for him. Philip, again, somebody who was on unit dialysis, knew exactly what that involved. When he left dialysis, he went home, finished with, and everything was working very well for him. Owain, said, that other person that was on dialysis with him had been on dialysis for 37 years. That was really, really big for him. He was a young person on dialysis, but to see other people that had been on dialysis a long time had given him that hope as well, that actually he too could live a very long life on dialysis. And that was something he really wished to share. And Alan, unless you tell me differently, so Alan hadn't started dialysis, and he felt really that actually, unless we told him any different, he didn't feel ill enough to make a decision. Didn't have any symptoms, and kind of was ignoring it in the best way that he could. didn't know whether that was denial, but he said, for him, that's what he was wishing to do at that time. But again, there was a few people that I'd interviewed that were not on dialysis. So this kind of gives a little bit of an understanding that people were feeling well, didn't need to make a different decision as well. And that was really, really important for me to also understand, to be able to share that people felt that they'd made the best treatment decision for them. They were feeling well on the dialysis, or their current, they're not being on dialysis. And for seeing other people that had been on dialysis a long time also gave them hope that they too could dialyse as well. And quality of life was really, really important. That it was highlighted that that was the best treatment at this current time for them. Next, I think it might be the next question.
Sam's question's an important one, I think, which is, and I don't know whether your research covered this or not. Did you explore how much of these concerns had already been explored, and how much depth with their professional teams? Or is this the kind of, some of these things maybe the first time this stuff had been aired?
That's a really, really interesting question. So for some people, their kidney teams knew their decision, but they didn't feel, certainly for some people, didn't feel that they'd been listened to. And really, this was the first time when they shared their, their experiences with myself, or their reasons were the first time that somebody had actually understood. And I think that, as I said, some people were then being referred because they had said no, they didn't want to transplant, that they were being referred then on to like clinical psychology to see, what were their reasons. And one young woman said, okay, you keep pestering me, I've made my decision, but okay, make me an appointment with a clinical psychologist. What's that going to prove? I've made a decision. What was really important for me, and based on that question, I think you said Sam, wasn't it, that I had questions that I'd pre-shared with people, but it was really important for me to kind of give that opening, tell me about your experiences. And people explored that in so many different ways. And then by piecing together the picture, then bringing things together that were almost like collectively similar, and then what was quite different. So people did, had information, they had education. Some people then had decided, so I can certainly remember many conversations as well where people said, yeah, I've had all that information, thank you, give it to the next person because I'm just not interested. And that was really something that was quite important, that people may have information at different points of their kidney journeys, but then hadn't had that either revisited because they just had no thank you, you can keep bringing me this information but I don't want it, versus then other people that had then received all the information but then couldn't quite work out then what that still meant for them. So one gentleman that was in his 70s said, well, okay, well, this many people at my age do okay, this many people don't do okay, well, where am I? What does that mean for me? And I think being able to interview so many people, I was able to hear lots of different variations of story, and that was so important to kind of capture. But yes, people had either really explored with their kidney teams versus those then that had said, no, actually, I've made a decision, I've had all the information, I don't want to keep exploring things. But everybody, did highlight really what that kind of conversation looked like, and how then they'd gone on to make their decision.
Okay, should we go on to the next question? If there's any questions from the audience at all? Nothing new. So I guess wrapping things up then, Emma, what do you think that we should be doing with these? We as in healthcare professionals, but we as in kidney community, patients, relatives, what should we be doing with this new information that you've been able to provide for us?
Okay, so I have put some summarised points as well on the next slide, but it'd be really good to, I think most importantly is making sure that people have their options, and we've put this here, I think at the very beginning as well, is for people to understand what their choices are, then what's good about that choice, bad about that choice, to be able to really understand what the benefits, the risks are, and then also then, what's really important is the benefits and the risk, but then what happens if I do nothing or don't make a decision. So I think again, that's again quite valid. We understand everything. I'm not going to, or I will, but what happens if I don't make a decision now? I think that's quite important then that is then re-explored at different time points with that person. And then making sure that people are getting the support to help them make the decision. But more importantly is understanding what's important to that person. Getting them to write down as well what is important to them. Is it quality of life versus the, so many years? Some people explained, well, okay, I may have a really terrible 5 years for having a transplant, but I might actually have 3 really good years on dialysis. So it's trying to understand what is important for that person and kind of like exploring that, what is in, what makes that decision for them, the most important decision for them and their families. And then the next slide then just goes into some just key points really. And I think it's really important that, again, I'll just skip, just read over these, but people's earlier life experiences really did affect the way they made decisions in some way. Younger and older people described ways that they'd felt sad and they had loss when they found out they had kidney disease diagnosis. Ideas and negative perceptions and exposure to other people's negative experiences really did influence people's decisions. People felt adjusted to being on dialysis and felt they were able to lead a normal life. That normal life for them that didn't carry uncertainties and burdens of a transplant, and they considered dialysis was the best option for them. People on dialysis at home felt that they had quite similar outcomes to those people that had been transplanted. People in this I hadn't explored in some of the other slides, but people felt quite pressured as well to consider living transplants and didn't want their families and loved ones to come to harm for them. And some people had uncertainties and negative ideas and beliefs about receiving a transplant from somebody else. So that, again, that was something that was quite important, that didn't really know how they would feel about receiving a transplant from somebody else for them to live. People who've been previously transplanted didn't want to take the risk and uncertainty of another transplant. And then when people declined offers of the transplant, there were the various reasons that were shared. So inconvenient, or wanted the kidney to be given to somebody else who deserved the kidney more than them. So I think for people who are here, it's probably validating really that decision if they don't want to transplant, that we need to understand as healthcare teams why they're making the decisions, but also if they've made decisions that we need to understand, have we explored them fully with people? And then really as well for families to understand where people are making their decisions, people who were interviewed alongside their loved ones. Some of the loved ones, on hearing what the person's reasons were quite, at times quite distressed because they hadn't really understood their reasons from them, that they were hearing the reasons, but maybe weren't really understanding. So it's really, really important that we, that people feel heard, and really their reasons need to be, understood in every way. I can see a couple of questions have popped up, so I'm just aware of time as well. Mike did say I would talk forever, so
It's only been an
keep me
hour.
on
I'm
track.
amazed we've kept
Keep
it
me
to
on
that
track.
short, to be honest. Richard's question is dialysis a long-term or short-term solution? So dialysis and kidney transplants are both treatment options for somebody who, when they've got advanced kidney disease. So they're both treatment options. They're not cures, either of them. They're both really good treatments, but each has their advantages and disadvantages. And this is exactly what I'm always saying there with ask the questions, tell me what the pros and the cons are of each. In general, dialysis is normally a longer term. It will keep people well for a long period of time. It has some disadvantages to it, mostly about restrictions of where you can be. You've got to be able to do your dialysis. Some restrictions on your time. It takes quite a lot of time each week to do these dialysis. Sometimes restrictions on fluid and diet and things like that. Um, and a transplant as an alternative, most of that is about removing those with restrictions. Um, but then you have to trade that for some different risks, the risks of having a surgical procedure and the risks of taking the anti-rejection medication. So that's the balance that we're looking to help our patients to navigate through and make the decision on. Um, Negative perceptions. So this is from Helen. Negative perceptions. Had the people who had those negative perceptions had the opportunity to hear from others who had positive experiences. Um, I guess that the research won't necessarily have gone into minutiae about every individual case, but obviously there is all of the education programs around Wales certainly do have programs where you can education programs where you can hear from actual patients about what all the different options have. Um, I think sometimes perhaps if we haven't gone into as much detail as Emma has here, so to actually understand in full detail with every individual what their concerns are, it's possible that we haven't then explored the balancing act of describing that in a bit more detail. Emma?
And I think thanks, Helen, for that question. It's really clear as well to understand that all the people had made informed decisions and they collected all that information for themselves to make a decision. And that, as I said, nothing, there wasn't just one reason, there were so many multiple reasons that almost like were entwined with the various reasons. And people really did describe how they'd weighed up their information, how they'd weighed that, for their own decision-making processes. So I wouldn't say that anybody, everybody really articulated such, in, the way that they shared their experiences really did like give me that understanding of their journey, what there was unique to them. It was shared across so many. When I think, when you're looking at people, as I said earlier on, collectively, but they were very intricate details, from their own experiences, and people were very articulate with what they shared. They really did provide so much depth for me to make, start being able to pick up some of these things to bring to the kidney community, and let's say within the publication and things, this it wasn't just I've made a decision. People had really carefully thought about that decision, and that was based on information they'd had and lots of points where they were able to pick up other experiences from other people. I hope
Yeah,
that helps.
thank you, Emma. And then there is a comment there from one of your previous patients. Alan has said that he'd had a transplant and carefully considered whether he wanted to have another one. Ultimately did go ahead and is now 7 years on, doing very well and mentoring, which is really excellent to hear. So,
Yeah,
Alan,
thanks,
thank you for
Alan.
sharing
That's
that.
really, thank you for giving that as well. I see. Yeah, that's so lovely to hear from you.
Good. Well, we've overrun a little bit. Thank you, Emma, for all that insight. Really interesting research and some nice discussion there. Georgia, anything else before we wrap up?
No, that looks like that's all the questions we've got for today. So thank you all for joining us today. We hope you found the session informative and thought-provoking.